Hi everyone, this is Ahmed Alwaidh, and today's webinar is going to be about magnification and endodontics. Is it an accessory thing or substantial? So I graduated with a BDS from University of Baghdad. I also have MSc in endodontics from King's College London, and also LDS from the Royal College of Surgeons of England. I'm a gold certified member of Sal Italian Endodontics and also lecturer in endodontics at Jaume University. I'm a qualified dentist in Iraq, Dubai, and the UK. So first, before we jump to magnification, we need to discuss why we do root canal treatment. So in 1965, Samuel Kakashi made fantastic research or paper where he brought 36 fisher rats, and these rats were into two groups. So the first group was the control group, which they have normal oral flora. They're not diseased, but they have normal oral flora. And the other group was experimental rats, where they didn't have any oral flora. They were raised and under laboratory settings. So they were the germ-free food. So both groups, they were fed with germ-free food and distilled water. So what he did intentional pulp exposure in both groups for the molars of these rats, and he left these exposures without any seal. And the animals and the debris, food debris and saliva, everything was entering inside the pulp because the pulp were exposed. So the animals were killed at intervals from 1 to 42 days post-operatively to examine the tooth and periradicular tissue histologically. All perforations in both groups were packed with food debris. So for the control group, after 8 days, complete pulp necrosis. Again, those are not diseased. They have only normal flora. So complete pulp necrosis after 8 days with a chronic inflammatory, it means established inflammation and abscess formation in the apical areas. And a few specimens, they were exhibited microorganism in the soft tissue beyond the apical foramina. Abscess were also found in lateral canals, accessory canals, and there was no evidence of repair. While the germ-free food, although the pulp were exposed and food was packed inside the pulp, so all teeth were survived the experiment, and there was no evidence of any inflammation, only minor inflammatory process at the entry or at the exposure. Dentinal bridging was already evident at 14 days, and yeah, all specimens survived. So that means our problem or our issue is with bacteria. This is why the European Society of Endodontology, they have identified endodontics or endodontology is that branch of dentistry that's concerned with anything related to the pulp and radicular tissue. The main disease we are talking about is not pulpitis, is the apical periodontitis, which is caused by infection. So what is the aim of root canal treatment? Is to prevent or cure apical periodontitis, and we do that in two main steps, which is first we need to eliminate the causative factor, which is a bacteria, and then we need to seal the root canal system with a hermetic seal to prevent reinfection of the root canal system. And that means we need to remove all vital necrotic remnant of the pulp tissue, bacteria and toxins, biofilms from the root canal system by a chemomechanical debridement. And then we need to seal the root canal system with a hermetic seal. That may sound, it's an easy thing because we always think that the root canal system is only lines because we see that on x-rays, which is 2 dimensions. But actually, in fact, the root canal system is very complex 3-dimensional system with a lots of anastomosis, lateral canals, fins, many portal of exits. So that means we need to remove everything from these complexities and then we need to seal it. So according to Prof. Arnaldo Castellucci, in his paper 2003, he said, until recently, the endodontic therapy was traditionally performed using tactile sensation of the clinician, and the root canal system could only be observed radiographically, which is two dimensions. So it doesn't represent the actual fact of the root canal system. So to perform an endodontic therapy often meant to work inside a black hole, and many results were achieved by chance. So for that reason, magnification is very important in endodontics. But the question is what we use, loops, dental loops, or the dental microscope? Well, dental loops are very beneficial, actually, in not only root canal system, but nowadays in all aspects of endodontics. I see surgeons, they're putting implants using loops. Pedodontists, they are using loops. Periodontists, they are using loops. For me, I'm a microscope user, but I cannot do any diagnosis without loops. I'll be honest with you. So what to use? But what is the difference between loops and microscope? There are main key differences between them. With microscope, it's more comfortable to work with because of the ergonomics, and you have better vision, of course, because you have higher magnification or more magnification, and most importantly is the illumination, which is the axial light. So this is very nice description of what we get when we use magnification compared to naked eyes or glasses, or 2.5 loops or 4.8 times loops with headlights or the dental microscope. As a dentist, most of the dentists, they complain of their vertebrae they have from neck or lumbar. With the loops, you will have your back straight mostly, but your neck is bending. But with a microscope, no. You will have both straight, your neck and lumbar back. So most important thing, the main difference for me, microscope than loops, is because of the axial light, because you don't have any shadows. Because the concept of vision is that we see objects because of the light reflecting from the object. With the loops, we have two lines of vision and one line of light. So the light is going to the subject and they're reflecting in different angle. So you may have shadowing, but in the microscope, no, it's the same direction of the light is going to the object and they're reflected. So you don't have any shadowing. So that means you have deeper, you can access deeper part of the root canal system with the microscope. The uses of magnification or microscope, especially in diagnosis. So in this paper, they mentioned that persistently painful tooth after endodontic therapy may be due to untreated missing canal, like MB2 and maxillary molar. So accessing these teeth again after primary root canal treatment, they could find a missing or missed MB2 by the microscope. So locating missing or hidden canals. So in this paper, same paper, they mentioned that as discussed in many sections in this issue, the most important utility of the microscope in non-surgical endo treatment is to locate hidden canals. The canal anatomy is extremely complex. Often dental anatomy is not that predictable. So what they mentioned that in introduction of microscope to graduate endodontic program at the University of Pennsylvania in 1992, it has been found that nearly 50% of all molars, maxillary or mandibular, have a fourth canal. More than 30% of all premolars have a third canal. 25% of all anterior teeth have two canals. This is after using the microscope. So comparing these teeth with naked eyes and with the microscope. So what they mentioned that what was considered as a rare exception in the past has become a routine finding when using the dental microscope. So another paper, they found that 78% of mesial roots of upper first molars and half of maxillary second molars have two more or less separate canals in the mesial root. So most of these were MB2 and could only identified by the using microscope. We are talking about high percentage. So 78% of the cases we might have missed canal because we are not using microscope. Another paper with the naked eye, total of 641 canals were seen in all teeth with the naked eye. But after examination with the dental microscope, 50 more canals could be visualized. So that's representing 7.8 increase what they're using of dental microscope. And also, not only the canals, but also the orifices. Another paper they mentioned, it was concluded that the detection rate of root canal orifices under a microscope was significantly higher than that with the naked eye. And the use of the surgical loops was relatively ineffective compared with the microscope method. Okay? So another paper, they concluded that the operating microscope enhanced both the detection and negotiation of accessory mesial canals in the mandibular first and second molars beyond what could be achieved with the aid of the loop. So now we are talking about lower molars, accessory canals. Okay, so 14% increase in the lower first molars and 18% increase of lower second molars. We are talking about extra canals that could only be found, or orifices only be found by the using of microscope. So this is an example. In this case, in the X-ray, this is upper first molar. You see a normal tooth, nothing strange. But after access opening, it was possible to find two mesial canals, two distal buccal canals, and one rare anatomy of palatal canals. So total 5 canals. The distal buccal system, it had 2 canals, but they were merged together after a root canal preparation. And this is, if you can see with the obturation, we have 2 mesial canals, 2 distal buccal canals, and 1 palatal canal. And that was only possible by the using of microscope. This is another case of lower first molar, second molar. If you can see, everything is normal in the microscope, but it was possible to locate an extra canal in the mesial root. So instead of 2 mesial canals, it was possible to find 3 mesial canals. Okay, and this is another example of lower second molar. Okay, if you can see in the radiograph, you can see second molar and third molar. The first molar was missing. So also 3 canals in the mesial root and 1 wide canal or large canal in the distal root, which was obturated by MTA, the distal root. And here we could find the extra canal in the mesial root. By the way, extra canals, majority of extra canals, lower molars, it can be found in the mesial root. However, look at this case. It was referred by a colleague because he couldn't get a reading of apex locator, so he didn't know what was the problem. So after careful examination, there were 2 canals in the mesial root, but in the distal root there were 3 canals. This is why he was getting he couldn't get a reading of apex locator because there were pulp tissue left in the canal, so he couldn't get a reading. So see, in the mesial root now we have 2 canals, but in the distal root of lower molar we had 3 canals. So total 5 canals. And if you can see in the angulation of the radiograph, it was clearly evident. Now this is upper second premolar. From the X-ray, you can tell that there was a single canal, then suddenly disappeared. We all know that it's merging or into 2 canals. But after careful examination in the microscope, no, there were 3 canals, not 2 canals. And the third canal was very difficult to locate, okay, even with the microscope. But without microscope, it was impossible to locate. So this tooth was mini molar. How about calcified canals? with the normal vision or low power loops, calcified canals in the pulp chamber is not detectable. But when the calcified canal is looked through the microscope at high magnification, high power illumination, the difference in color and texture between the calcified canal and the remaining dentine can be easily seen, especially if you know how to follow the pulp map. So look at this upper first molar. It was referred by a colleague because he couldn't locate the canals. So of course it was impossible because he didn't do a proper access opening because he was not using any form of magnification. So everything was black. He thought this was the pulp chamber. Actually, it was the pulpal roof. So after good access opening, removing all flame tissue, that was the pulp chamber. Even though with the magnification, the microscope, I couldn't find any orifice. But the microscope enabled me to identify the pulp map. So I followed the pulp map and I could locate the orifices. So here in this scenario, or in this case, the microscope couldn't let me to identify or find the orifices, but it was possible to follow the pulp map to locate the canals. I didn't find only the major canals, but also the extra canal, which was the MB2. Okay, and this, if you can see, everything was perfect. Also, this is another case. There was no canals at all, but we know there were canals. Why? Because there was infection, so it means bacteria. So it means that there is canals. So after locating the pulp map and careful negotiating of the orifices and the canals, it was possible to finish the root canal treatment of this tooth of upper premolar. How about retrieval of broken file? The dental microscope is essential. Actually, it's impossible to retrieve a broken instrument or a broken file without a microscope. Why? Because you need to see the fragment and you need to work around the fragment with minimum space or minimum room. So the broken file can be removed while minimizing the damage to the surrounding dentine. So minimal invasive dentistry. So in this paper, they concluded that the location of the fragment and the anatomy of the root canal influence the success of fracture instrument management. Ultrasonics under the visualization of microscope is an effective removal method. Like in this case, it was referred from a colleague. After examining under the microscope, it was easy to find or to see the fragment, the broken instrument. With ultrasonic, it was jumped in the pulp chamber, and the patient was referred back to the referral dentist. And this is another example also of a referred case. You can see very easy the fragment, the broken instrument. With ultrasonic, it was easy to remove the broken file. That doesn't mean that with the use of dental microscope you can remove all broken instrument very easily. No, it depends. It depends on many factors: the location of the file, the diameter, the type of the file, how is the anatomy of the canal. Too many factors actually, and this is the broken instrument. With the use of ultrasonic, the removal of posts, calcification, and broken instrument is faster, safer, and easier. To locate missed canals or negotiate calcified canals is more predictable using the ultrasonic tips under the microscope. So how about removal of pulp stones? In this case, also referred case, it was, you can see that the pulp chamber, there was a big stone. Without the microscope, you will never find it. And you may think, no, this is the pulp chamber. But with the microscope, you can differentiate the color of the pulp chamber or the pulp map, which is usually dark gray, and the pulp stone, which is usually yellowish or brownish. And you have to remove all stones because they were infected tissue or necrotic tissue underneath. So it was dismantled by the use of special ultrasonic tips and then fractured to small pieces to take it out of the tooth And now you can see this is the pulp chamber. This is a clean pulp chamber without any stone. Why? Because with the magnification and illumination of microscope, we can differentiate the different colors. How about perforation repair? Perforation it happens, no matter how carefully the tooth is accessed for endodontic therapy. But when perforation occurs, the microscope is the key instrument to identify and evaluate the damaged site. The results of a careful inspection will be the basis for which the preparation of the perforation repair will be made. So this is a case, also a third case. There was pulp stone and there was also a perforation. So there was stone in the perforation. So the perforation site was cleaned by ultrasonics, then gelatin sponge, and the perforation was sealed by MTA and then covered by GIC. So I could finish the root canal treatment because of the washability or washout of the MTA. So without the microscope, it was impossible to identify and treat the perforation. And this is the final X-ray, and the patient was referred back to the referral dentist. How about white pieces? Like in this case, the patient presented. It was previously treated long time ago, and the tooth was opened. So after chemomechanical debridement, a gelatin sponge was placed, and then MTA was packed as MTA plug, and the thermoplasticized guttapercha, and this is the final result. You can see that this is straight canal. I could see even beyond the apex with the dental microscope. This is another case of lower molar. Also, the distal canal of this lower 7 was very wide. I could see easily. So I placed MTA, and this is the final result. And if you can see, because of the precision with the dental microscope, there was a lateral canal in the distal root which was filled by MTA. So even for root canal retreatment, when we do root canal retreatment, you should consider everything in the root canal system is infected. So when you do retreatment with the files and you have reached the apex, you have zero reading, you take X-ray, you see everything is fine, but not. Why? Because there are still remnants in the root canal system. It's impossible to identify with the X-ray, but with the microscope, you will see a lot of residual root canal treatment from previous treatment, and all of these are infected, and they are considered a source of infection. So with the microscope, you could see them easily. Even when you finish root canal treatment, you need final examination. When you finish the root canal preparation and when you finish obturation. Why? Because pulp chamber should be cleaned thoroughly from the remaining root canal material. Why? Because nowadays we are using adhesive dentistry, and any residues will affect adhesion and thus leading to reinfection, leakage, and reinfection. Like in this case, after I finish preparation, I dry the pulp chamber, examine. Maybe I missed a canal, and after I finish obturation, I clean everything from the pulp chamber to enhance adhesiveness. How about cracks? Cracks are very easy to detect under the microscope. Even especially at high magnification, we are talking about 16 times or 24 magnification. With a focus light, a microfracture can easily be detected, and sometimes we need to use methylene blue. Like in this case, it was upper 7, upper 2nd molar. If you can see, there were pins, and very easy to locate or to see the cracks. And also there was a perforation actually in that root, and it was impossible to locate without the microscope. This is another case while after removing the amalgam filling, you can see very easily the running horizontal crack with the light and magnification of microscope. And also this is another case presented. One of them, I can tell an important diagnostic tool we should use actually in every case. We need to check with a perioprobe. We need to check all around any tooth we treat. This tooth may look normal to you, but when we use the perioprobe, the pocket depth normal should be between 2 to 4 millimeter. And I could see crack here, but see here is normal, but here no, drop. So this is crack tooth syndrome. This is vertical root crack or vertical, which lead vertical root fracture. See, here is normal, but at the crack site, no, the perioprobe drops. How about surgery? According to the ESC guidelines, that surgical endodontics is done by endodontists, not by surgeons. Okay, so this is within our scope. And the use of microscope during the provision of endodontic apical surgery became commonplace from late 1990s. Why? Because of the very high and predictable success rate with the use of a dental operating microscope in endodontic surgery. This is very nice paper, been published in 2006. So it's a retrospective evaluation, a retrospective study evaluating surgical endodontic treatment, either traditional or modern technique. So there were 110 patients were treated with surgical endo treatment between the year 2000 and 2002. So either by traditional or modern technique. Traditional technique included root end resection with 45-degree bevel angle and retrograde preparation using carbide round burr, while the modern technique included root end resection with minimum or no bevel and retrograde preparation using ultrasonic retro tips with the aid of dental operating microscope. It was under microscope. So the conclusion, this is very important. Complete healing rate for the teeth treated with modern technique was 91%, which is highly significant, significantly higher than traditional technique, which was 44%. So as a conclusion, surgical endodontic treatment under the microscope highly improves the treatment outcomes compared to traditional technique. This is an example. Patient presented. She had swelling in her lower lip and everything. So I could diagnose that both lower centrals were necrotic because previous trauma. So after access opening, if you can see, there was pus, drainage, and two lower centrals. Each one of them had two canals, and for many sessions with mechanical debridement, good irrigation, ultrasonics, and also intracanal medication with calcium hydroxide. But after 4 or 5 visits, the pus was keep oozing. It was not stopping. So we went to the next level. We took CBCT, and it was evident there was some kind of cystic lesion or something there. If you can see, it's made expansion in the labial plate, cortical plate. So that means we need to go for surgical approach. So after raising a flap under the microscope, and we removed all the infected tissue, granulation tissue, and minimum root end resection, and retrograde cavity using ultrasonic retro tips and micro mirror. If you can see how the mirrors are small, and this is the reflection. It's 6 or 9 millimeter, but if you can see in the picture, it's very big. Why? Because of the microscope. Retrograde filling with the MTA, and this is the final X-ray. When you compare it to the initial X-ray, you can see it was minimum root end resection. So, use of microscope. This is a very nice paper. Okay, it was a questionnaire. Okay, it was for AE members, American Association of Endodontists members. That was in 2000 and in 1999. So they have found that the dentists, the endodontists, they're using the microscope was 52%. But after only 9 years, they made the questionnaire and they have found 90% of endodontists they're using microscopes. So only in 9 years. So messages to take home. But before that, we need to discuss Fanta microscope, because this is the one I've been using a year now. It's a very nice tool, very compact, very ergonomic, very light. I really like it. I use it in my daily practice nowadays. It has very nice features. It has the binocular. It's foldable binocular, and from 0 to 210 degrees. The interpupillary distance, you can it's adjustable. It's from 55 millimeter to 75, so you have wide range. It has built-in or integrated camera, which is Sony sensor. It shoots in high definition with 60 frames per second, crystal clear images, and with only one click in your hands, you can take photo or videos. It has also its own screen. So if you can see, I put it in this room. It's kind of not big, a medium-sized room, but everything is fine. I have two assistants helping me all the time. So very nice. The objective lens, it has wide range of focus, working length from 200 to 400 millimeters, and high magnification also. So now, for take-home messages. Magnification is essential aid in endodontics treatment, not the microscope. That doesn't mean if you don't have microscope or you cannot afford microscope, you work with your naked eyes. You have to use magnification. You have to use at least loops. Dental loops can cover wide range of endodontic treatment for everyday practice. We are saying, not talking about endodontists, specialist endodontists, but everyday practice. You're doing majority of root canal treatment, you can use dental loops. But also having dental microscope doesn't make you better practitioner, but good diagnosis, assessment of the case, good treatment plan, considering, of course, other treatment options and execution of the treatment in a systematic approach. That's what makes you a good dentist. But the dental microscope is an integral part of specialist endodontists. An important message, just like any other specialties, you cannot treat all cases. In some instances, you have to refer to specialist dentists. Thank you very much for watching. Please, if you have any question, feel free to ask in the comments, and I'll be more than happy to answer them. Until next time, take care.